Welcome to this presentation reviewing subjective global assessment and the utilization of SGA in the clinical setting. SGA is a validated and reliable instrument for detecting nutritional status at a given point in time, meaning the tool should be used at important intervals of a patient's care, like admission to the hospital or admission to the ICU. Performing SGA daily will provide little information for changes in hospital status. Findings from the assessment are mainly subjective, therefore, we evaluate a number of potential indicators of malnutrition to verify diagnosis. Together, weight change, dietary intake, GI symptoms, functional capacity, metabolic stress, and physical examination are determined to measure nutritional status. The next step is to classify the weight loss. Detsky et al., the original author and developer of SGA, suggests the following criteria. A 5% weight loss in 6 months represents a small change. A 10% weight loss in 6 months represents potentially significant change, and a greater than 10% weight loss in 6 months represents a definitely significant change in weight. Blackburn et al. Defines significant weight loss as 1 to 2% decrease in body weight over 1 week, a 5% decrease in body weight over 1 month, a 7.5% decrease in body weight over 3 months, and a 10% or greater decrease in body weight over 6 months. If a patient has lost weight over the 6-month period of time, but then began to gain it back, consider this patient to be at lower risk. Patients may be considered well-nourished if there is a recent stabilization in weight. Weight change is then categorized into one of 3 options. A equals no weight loss or a non-significant loss of weight with a regain. B, a weight loss is present, but the weight is now stable with no regain. Or C, significant weight loss with continued decrease in weight. Dietary intake is assessed as changes in oral intake in the previous 2 weeks. It's measured subjectively as a change in intake relative to normal intake, and it's classified as no change versus change. If a patient states that they do have a change in normal intake, it's then important to determine the duration. Is this change been a week, or has this change been 2 months? Also, what percent of normal intake is the patient currently consuming? Have they only been able to eat 50% of normal intake over the past 2 weeks, or has it been 0% of normal intake over the past 6 months? Additionally, dietary intake can be categorized by type of change. Can the patient tolerate solid food but only eat 50% of meals? Are they dependent on a hypocaloric liquid, a full liquid diet, or has there been complete starvation with inability to tolerate PO? Dietary intake is then categorized as either A, no change, or borderline poor intake but increasing, B, borderline or decreasing intake with no recent increase, or C, poor and decreasing intake. GI symptoms that have been persistent for the past 2 weeks are also recorded. Patients are asked, have they had nausea, vomiting, diarrhea, anorexia, or dysphagia that may have impacted their ability to tolerate PO. Categorization of GI symptoms is either A, there are no GI symptoms, B, 1 to 2 GI symptoms have been present for the past 2 weeks, or C, multiple symptoms have been present for longer than 2 weeks. Functional capacity is assessed to determine if patients have had difficulty caring for themselves prior to admission. Patients can be asked, do you have difficulty ambulating around your home or neighborhood? Do you feel fatigue walking certain distances or walking up a flight of stairs? Have you had a decrease in the ability to care for yourself, whether it be bathing, procuring food, or preparing meals? Do you have difficulty getting out of a chair or getting out of bed? If patients indicate that they have had a decrease in their functional capacity, the duration of the time period should be defined. Additionally, since these responses are so subjective, a hand grip measurement may be an important tool to determine a patient's strength prior to admission. Functional capacity is then defined as either A, no change, or a slight decrease that is now improving, B, decreased ADLs or poor hand grip strength. Notice in this example that exact number for hand grip strength isn't provided because there really are no standardizations related to hand grip strength in a normal population. My recommendation for you, if you want to use hand grip strength to assess functional capacity, is to perform the measure on yourself and then use that as an indicator to determine a patient's relative hand grip strength. And then finally, C, the patient is bedridden, they have a progressive decline in functional capacity, or they're unable to complete a hand grip measurement. Metabolic stress is assessed to determine if the underlying disease state is leading to an increase in resting metabolic rate. Examples of admitting diagnosis that are not associated with an increase of stress would be a GI bleed, diabetic ketoacidosis, or hypertensive urgency. Low stress could be a chronic non-infected wound. Moderate stress could be a patient that's admitted to either the hospital or intensive care unit with pneumonia or a UTI, where high stress is an example of a septic patient. Categorization of metabolic stress is either A, no stress, B, low to moderate stress, or C, high stress. Another way to think about metabolic stress is to determine what kind of calorie recommendations would you make for a patient. An example of where you would only recommend 25 calories per kilo would be a no stress patient. If you would recommend 25 to 30 calories per kilo, that would be an example of a patient with low to moderate stress. While if you were going to recommend 30 to 35 calories per kilo, that would be an example of a patient who is high stressed. The evaluation of physical assessment findings is the last step of SGA. Changes in subcutaneous fat stores are determined by examining fat pads under the eyes and fat stores in the tricep area. Changes in muscle depots is evaluated by examining the clavicle, shoulder, and quadriceps. Presence of edema is determined by examining lower extremities, and presence of ascites is determined by an abdominal exam. Remember to consider physical assessment findings in context with the other components of SGA. For example, patients do not need to have a change in weight to discover significant physical findings. And many times a patient's weight may be stable, when in fact fat depots have declined, but this change has been masked by an increase in overall fluid status. Physical assessment findings are more significant when they are coinciding with decreased dietary intake, GI symptoms, and a decrease in functional status. And finally, a normally thin patient may appear to have significant physical assessment findings, but the rest of the SGA indicates that the patient is actually normal since they've had no change in weight, no dietary intake. They are just normally thin. Let's talk more about specific physical assessment findings associated with a decrease in subcutaneous fat stores. First, look at the fat pads directly under the eyes. In this example, it's a picture of Patrick Swayze before he had cancer. And he represents a normal appearance where the fat pads fill the under eye space and appear as a slight bulge. As patients lose the fat pad around the eyes, the outline of the eyeball and the eye socket is more pronounced. Additionally, darkened areas can be seen under the eye. The skin around the eye may also have a loose or hanging appearance, and the cheekbones may be more noticeable. In this example of Patrick Swayze after cancer, you can see a depletion in the eye fat pad with a more pronounced eye socket and cheekbone. Loss of fat padding under the eye can be then categorized as A, the fat pad is present, B, there's a slight depression with darkening of the skin, or C, The area under the eye is hollowing with a significant depression. Next, the tricep is evaluated to determine fat stores. First, locate the midpoint of the tricep, located halfway between the top of the shoulder and the elbow, as if you were performing a skin fold measurement. To determine subcutaneous fat stores, grasp the skin between your fingers. You can determine the amount of subcutaneous fat present by rolling the skin fold between your fingers, since subcutaneous fat stores lie directly under the skin. When no or minimal fat loss has occurred, the fingers will not touch. I recommend practicing this technique on yourself and your friends and family. But remember, in normally lean individuals, the fingers may come close to touching since these patients do not have a large fat pad at the tricep area. Fat store depletion can be detected as the depot of fat is decreased, but a large volume of skin remains. When you grasp the tricep midpoint in these patients, the fingers will almost meet. And finally, if the fingers meet when the tricep is grasped, the loss of fat is severe. Another method to determine subcutaneous fat stores is to ask the patient to hold their arm as if they are stopping traffic. In normal findings, or patients who have not had significant fat wasting, the fat of the tricep area may sag, but there will be no significant change in tone. If a patient has had significant fat wasting, you will notice a surplus of skin that will almost hang like a chicken wing. Again, you could grasp this area with your fingers, similar to what we did with the tricep, to determine the amount of fat pad that is present. Fat loss of the tricep area can be categorized as A, the fingers do not touch, B, the fingers nearly meet between the fat pad, or C, there is significant fat wasting and the fingers touch. Finally, categorize the patient's sub-Q fat stores to assess overall fat wasting. A, there's no obvious loss. B, there's mild loss of subcutaneous fat stores. B, moderate loss of subcutaneous fat stores. Or C, severe loss. Next, we will evaluate muscle stores by examining the clavicle. Look along the lines of the clavicle. In men, the outline of the clavicle should not be visible. In women, an outline of the clavicle should be just visible. As the chest muscle mass is depleted, the bones of the clavicle will become more prominent. As mild to moderate muscle wasting occurs in men, the bones of the clavicle will become visible, and among women, the clavicle is very prominent, but the chest wall remains intact. In severe muscle wasting, the clavicle is quite prominent. The muscles of the shoulders and the ribs can be seen through the chest wall. Clavicle muscle wasting can be categorized as A, not present, B, in males, a portion of the clavicle is visible, in females, the clavicle is prominent, but the chest wall is intact, or C, evident protrusion of the clavicle. Next, evaluate muscle stores in the shoulder. Position the patient with arms at their side. The shoulder should have a curved appearance. Palpating the deltoid should feel like touching a chicken breast or a bag of flour. You should be able to grasp muscle tissue at the shoulder joint. As muscle stores in the shoulder begin to deteriorate, the deltoid will have a squared off appearance and the bones of the shoulder will be visible. Now that you've evaluated the stores of the shoulder area, it's time to categorize your findings. A equals no change in muscle status. B, the deltoid is wasted and there's minimal tissue at the shoulder joint. Or C, the shoulders have a squared off appearance with the bones prominent. Finally, examine the patient's leg. The volume of The volume of the quadricep and calf will be depleted among patients with muscle wasting. A minimal difference in size is observed between the two muscles, and upon palpation, the quadricep may feel like risen dough or a deflated balloon. Categorization of muscle loss at the quadricep can be A, no change, B, depleted volume, or C, thin appearance, no differentiation between the calf and quadricep. Ascites can be evaluated by examining the abdomen. Normally, the abdomen will be symmetrically flat or rounded, depending on the patient's weight status. In ascites, the abdomen will have a protuberant appearance with bulging flanks. It can be assessed by identifying a fluid wave. Press the edges of both hands firmly down the midline of the abdomen. Have someone tap one flank sharply with fingertips. Feel the opposite flank for an impulse transmitted through the fluid. If you can feel an impulse transmitted through the fluid, ascites is present. Ascites can be categorized as A, no ascites, B, mild ascites, or C, severe ascites leading to shortness of breath and anorexia. After you have evaluated each component, an overall SGA score of A, B, or C is assigned. The overall score should rely heavily on the evaluation of weight loss, dietary intake, GI symptoms, functional status, and physical examination. For example, a score of B would represent a patient who had greater than 5% weight loss with none of the weight regained, a decreased intake with mild fat and muscle loss, while a score of C would represent a patient who is demonstrating obvious physical signs of malnutrition with significant weight loss along with other markers. We have completed an SGA form that will help in your assessment. Let's start by reviewing a case study. DL is a 61-year-old female with a history of diabetes, hypertension, CHF, AFib on Coumadin, admitted with an abdominal hematoma and a decrease in hemoglobin. She's had a significant weight change in the past 6 months with a history of poor intake, anorexia. She's had no change in physical capacity. Her physical exam reveals normal fat and muscle with the presence of edema. Based on each of the components of the SGA, the patient is assigned an overall score of B. Next, JD is a 61-year-old male with a history of Hep C, status post a liver transplant, obesity, status post a failed sleeve gastrectomy, complicated by a fistula with subsequent total gastrectomy with a Roux-en-Y and a J-tube, admitted with diarrhea. He's had a significant weight change. His dietary intake is a general diet supplemented with J-tube feedings. He currently is admitted with diarrhea. His functional capacity is decreased with whole hand grip strength, and his physical exam reveals mild to moderate I-fat pad and tricep wasting, mild to moderate clavicle deltoid and quadricep wasting with no edema or ascites. Again, based on all the components of SGA, this patient's overall score is B. Finally, JS is a 40-year-old female with a history of stage 4 bronchiectatic adenocarcinoma with known liver and bone mets, admitted with weakness and shortness of breath. This patient has also had a significant weight change. In this case, the weight is actually increased because of the presence of fluid. The patient is unable to eat prior to admission, and GI symptoms are anorexia with nausea and vomiting. The patient has decreased ADLs with low hand grip strength, and physical exam reveals severe eye and tricep wasting, severe clavicle deltoid and quadricep wasting with 2+ pitting edema and mild ascites. In this example, each of the components of the SGA point towards severe malnutrition.